Welcome to the Australian Dental Council 2026 Explainer podcast.
Thank you so much for having me.
Okay, so I want you to imagine a drill, but not just any drill. A drill spinning at 400,000 revolutions per minute.
Which is just a staggering number when you really stop to think about it.
Right. I mean, it's a velocity so extreme that it can literally slice through the hardest, most heavily mineralized substance in the human body in just a matter of seconds.
And you're operating that drill, less than a millimeter away from a patient's tongue or their cheek.
Exactly. Not to mention the incredibly sensitive living nerve tissue right there inside the tooth itself.
Yeah, the margins for error are basically zero.
So today we are taking a really deep dive into the source material from A Practical Approach to Operative Dentistry by Gordon B. Gray and Alaa H. Daud.
It's such a foundational text.
It really is. But our mission for this deep dive goes way beyond just listing out clinical tools like an inventory sheet.
We're not just reading a catalog here.
Right. We are unpacking the high-stakes physics, the intricate metallurgy, and the microscopic biology that actually makes saving a tooth possible.
Because the goal is to do all of this without causing catastrophic iatrogenic damage, right? Meaning damage caused by the treatment itself.
Exactly. So whether you are an undergraduate dental student laying down your foundation, or maybe teaching staff refining a curriculum, or even an overseas professional preparing for those brutal practical registration examinations, this deep dive is for you.
Or even just a practicing clinician looking to update your methodology. It really covers the absolute front line of reconstructive medicine.
Yeah, we're going to explore the really granular protocols here. The diagnosis of dental disease, the operative management of carious cavities, instrument control, and the strict architectural rules for restorations.
Both intracoronal and indirect restorations specifically.
Right. And the overarching theme of this entire deep dive is it's what the text calls the clinical art of minimally invasive dentistry.
I love that phrase so much. Clinical art.
I want to start right there, actually, because before we even look at a physical stainless steel instrument, there's this mandatory cognitive shift that the text demands of the clinician.
Yeah, it's a philosophical shift, really. It's about reorganizing your factual knowledge.
Right, because in those early years of training, a student's education is incredibly siloed.
Oh, completely compartmentalized.
You take a class on anatomy, then you go to another building for oral biology, you have a lab for biochemistry, lectures on pathology, seminars on material science.
They exist in these totally separate, neat little boxes.
But the text makes it clear that the second you sit beside a patient, all those silos just have to collapse. They have to fuse into one single integrated application.
And honestly, that cognitive integration is arguably the highest hurdle in any medical training.
It's tough. It's like, well, the text doesn't use this exact analogy, but I always think of it like a chef.
Oh, I like that. How so?
Like in culinary school, you learn the strict chemical properties of an egg or the exact melting point of butter.
Yeah.
That's your preclinical science.
Right, the isolated facts.
But when you're working a Friday night dinner rush, you aren't reciting chemical formulas. You have to master the real-time integrated art of cooking the meal.
That is a perfect analogy. You are transitioning from just possessing scientific facts to actually practicing an applied clinical art.
And you can't just apply minimally invasive dentistry mechanically, right? Like some rigid flowchart.
No, absolutely not. It has to become this innate, reflex-like understanding. You use it routinely for both diagnosis and operative problem solving.
Because in a textbook, a tooth is just this static, isolated white object on a page.
Right, but inside the actual oral cavity, it is a highly dynamic, incredibly hostile biomechanical environment.
I mean, it's dealing with massive occlusal forces from chewing.
Wild fluctuations in pH every time you drink coffee or eat an apple. Complex thermal changes from hot and cold food.
To ground this for you, the listener,
Well,
in a preclinical setting, you learn the strict chemistry of enamel. You learn that it's 96% inorganic hydroxyapatite crystals.
And you learn the histology of dentine with all its fluid-filled tubules.
But when you are holding that high-speed handpiece, you have to synthesize all that structural knowledge in real time.
You're reading the tactile feedback of the instrument while simultaneously assessing the depth of the lesion.
Right, and predicting how close you are to the pulp, calculating the microscopic angle of the enamel rods, all while fighting the patient's salivary flow so your composite resin doesn't just fail immediately.
And that synthesis right there is the difference between passing a written exam and actually saving a biological structure.
Because a written exam just tests your recall of isolated facts.
Exactly. Operative dentistry, on the other hand, tests your ability to continuously assess 100 shifting variables and deploy the exact correct physical and chemical interventions.
If you try to restore a tooth, but ignore the specific material science of the composite resin you're using, it's game over.
Or if you prep a cavity without visualizing the microscopic orientation of those enamel prisms at your margins, the restoration is doomed.
You'll get microleakage,
Microleakage, secondary caries, and eventually the total loss of the tooth.
which perfectly brings us to the very first point of contact between the clinician's knowledge and the patient's anatomy, the diagnostic front line.
This is where it all begins, the foundational instrument tray.
Right, this is the interface. And the most ubiquitous tool on that tray, the one everyone knows, is the dental mirror.
It seems so simple, but its function goes way beyond just letting you see the back of a tooth.
Indirect vision is the obvious one, sure, seeing the lingual or palatal aspects of the teeth.
But the mirror is actually this multifunctional dynamic tool. First off, it's used to capture and reflect ambient operator light deep down into dark, narrow cavity preparations.
Which is crucial. But the text really emphasizes its role from a safety perspective, too.
Absolutely. It is the primary instrument for tissue retraction.
Because the tongue and the buccal mucosa, the inside of the cheek, they are highly mobile and highly vascular.
They bleed a lot if you cut them, so they must be actively shielded from those sharp, high-speed rotary instruments.
If you have a momentary slip and you aren't using that mirror as a physical barricade,
You get severe lacerations. It's that simple.
now, there's a very specific optical distinction the text makes regarding endodontic procedures. Root canal therapy.
Yes, the front-reflecting mirror. This is fascinating.
Right, the protocol mandates a front-reflecting mirror for endo rather than the standard rear-reflecting mirror you'd have, say, in your bathroom at home.
Most people don't even realize mirrors are built differently.
I know. I mean, a bathroom mirror has that reflective silver coating on the back of a thick piece of glass. But why does that microscopic layer of glass matter so much when you're working inside a tooth?
Because it fundamentally alters the physics of the reflection, specifically the index of refraction.
Unpack that for us.
Okay, so in a standard rear-reflecting mirror, light hits the surface of the glass, bends as it travels through the thickness of the glass, hits the silver coating on the back, bounces off, travels back through the glass, bends again, and then enters your eye.
That is quite the journey for the light.
It is, and that journey through the refractive medium of the glass creates what we call a ghosting effect.
Like a faint double image.
Exactly. Now, when you look at your face in the bathroom mirror, your brain just filters it out. You don't notice it.
But inside a tooth.
Inside a tooth, when you are peering down a tiny endodontic access cavity, looking for a microscopic root canal orifice that might be a fraction of a millimeter wide, that double image is devastating.
You literally wouldn't know which image is the real canal.
Right. So a front-reflecting mirror eliminates that refractive journey completely.
Because the rhodium or silver coating is on the absolute top surface of the substrate.
Exactly. The light bounces off immediately. No glass to travel through. No secondary refraction.
So the image you receive is incredibly crisp and geometrically true.
Singularly focused.
Yeah.
Which is non-negotiable when negotiating complex root canal anatomy.
That perfectly illustrates how this minor shift in optical physics translates to a massive shift in clinical capability.
It really does.
So, moving from optics to tactile assessment, let's look at the periodontal probes on the diagnostic tray. The text contrasts the WHO probe with the Williams probe.
To the untrained eye, they look pretty similar. Just long, thin, metallic instruments with some markings on them.
But they are engineered for very different diagnostic metrics, right?
Entirely different phases of assessment. Let's start with the WHO probe. This is specifically designed for the basic periodontal examination, the BPE.
Right. It has that black band, usually from 3.5 to 5.5 millimeters. But the text highlights a very specific anatomical feature at the pip.
The BO.5 millimeter ball at the very end.
Why a ball end?
Because the purpose of that tiny ball is to prevent physical trauma to the delicate junctional epithelium at the base of the gingival sulcus.
Because the BPE is just a rapid screening tool.
Exactly. You are just doing a quick sweep of the sulcus to assess general attachment loss, find calculus, and check for bleeding on probing.
You want to feel for obstructions, but you absolutely don't want to accidentally pierce the soft tissue.
Because if you pierce it, you create false bleeding. And that would completely skew your diagnostic score. You want the biological reality, not iatrogenic trauma.
Makes total sense. Now, contrast that WHO probe with the Williams probe.
The Williams probe does not have a ball end, and it features incredibly precise individual millimeter markings.
Usually 1, 2, 3, 5, 7, 8, 9, and 10 millimeters, according to the text.
Right, so this is not a rapid screening tool at all. This is for comprehensive periodontal charting.
Where you have to record the exact architectural depth of the pocket at 6 specific sites around every single tooth.
Exactly. It requires a much finer tip to navigate those tight, diseased pockets so you can determine the exact level of bone loss.
Okay, that leads us to the dental probes used for exploring the hard tissues, the teeth themselves.
And checking the margins of existing restorations.
The tray includes the straight number 18 probe and the double-ended Brio probe,
The Brio has those angled, sharply pointed working ends.
designed to slip right between the teeth to detect interproximal cavitation. But this actually brings up what I consider to be one of the most profound paradigm shifts in the entire methodology of this text.
Oh, the stick test.
Yes. Historically, dentists were taught to take a sharp metal probe and just press it firmly into the dark fissures on the biting surface of a tooth.
Right, and if the probe stuck and required a little tug to pull it out?
That was the definitive diagnosis for a cavity. But the current protocol issues this stark, definitive warning against ever doing this again.
It is arguably one of the most vital clinical corrections in modern operative dentistry. That old stick test is now recognized as fundamentally destructive.
Why? I mean, how can just poking a tooth destroy it?
To understand that, we have to look at the microscopic histology of a developing a serious lesion. Dental caries does not start as a physical hole in the tooth.
It starts as a subsurface demineralization.
Exactly. The acid from cariogenic bacteria leaches calcium and phosphate out of the enamel beneath the surface.
But the outermost surface layer often remains intact, right? Supported by this fragile porous matrix.
That's a perfect way to visualize it. The tooth is hollowed out on a microscopic level, but the roof is still intact.
And the text points out that this intact surface layer is basically a biological miracle.
It really is, because as long as that fragile roof remains intact, the lesion can actually be reversed.
Right. If the patient improves their oral hygiene and applies fluoride.
Calcium and phosphate from the saliva can cross that intact surface membrane and remineralize the lesion from the inside out. The tooth can literally heal itself.
Okay, I see exactly where this is going. If you have this fragile, microscopically thin roof of enamel over a demineralized cavern.
And the clinician takes a sharp, hardened steel probe and drives it into that fissure with physical force.
You crush the roof.
You completely shatter that fragile surface zone. The diagnostic tool itself becomes the mechanism of irreversible destruction.
You cause severe iatrogenic damage.
Exactly. By physically fracturing that weakened enamel, you have permanently destroyed the remineralizing front. The tooth can no longer heal itself naturally.
And it gets worse, right? Because you're also pushing bacteria inside.
Oh, absolutely. By breaking that seal, you simultaneously drive the highly concentrated cariogenic bacteria that were residing on the surface deep into the now exposed porous lesion.
So you have actively accelerated the exact carious process you were merely trying to diagnose.
It completely upends the concept of intervention.
Diagnosis in this context requires an incredibly delicate, almost defensive posture.
It mandates a highly delicate tactile exploration. When a clinician uses that Brio probe to check for cavitation between the teeth, the protocol demands it be used with feather-light pressure.
You are merely gliding the tip over the enamel.
Just feeling for surface texture anomalies, or maybe the slight catch of an existing cavity margin, you are feeling the topography. You are absolutely not testing the structural load-bearing capacity of the enamel.
That is such a brilliant distinction. So let's move forward in the timeline. Let's say the disease has been carefully, safely diagnosed. Remineralization is no longer possible.
Cavitation has already occurred.
Right. So the infected tissue must be physically removed. We transition to operative management, the mechanical excavation of gregarious tissue.
And we start with the hand instruments here, specifically the excavators.
Excavators are these highly specialized hand tools engineered to physically pare away soft gregarious dentine. And their functional design dictates their exact clinical application.
The text details three main types. First, you have the 2123 spoon excavator.
It has a concave upper surface, hence the name spoon.
Right, and it has a relatively short neck. That short neck intentionally limits the depth it can reach down into a cavity preparation.
And then we have the 1334 discoid excavator.
Named for its flat upper surface, this one features a significantly longer neck, which allows the clinician to access the deepest, most apical parts of the lesion.
And finally, the large 1256 discoid excavator.
which has a massive working end. This is utilized for the rapid bulk removal of macarious tissue in very large, wide-open lesions.
So the names describe their shape, but the mechanics of the cutting action are what really stand out in the text. The working end isn't just a scoop, it has a sharp leading edge.
Yes. And the operational protocol specifies that this edge is used to cleave the carious dentine.
Not scrape it, not grind it, but cleave it.
Exactly. And the protocol is very rigid about the direction you move the instrument. You must use the excavator starting from the central, deepest area of the cavity, working your way outwards toward the periphery.
Toward the enamel walls.
Yeah.
But why is that center to periphery workflow so critical? I mean, why not just clean up the outside edges first?
It all comes down to strategic cavity design and strict biological infection control.
Okay, break that down for us.
Think of a carious lesion as a crater of infection. The absolute center is this necrotic mass of dead collagen, severely demineralized tooth structure, and literally billions of active bacteria.
Nasty stuff.
Very. Now, as you move outward toward the edges, the enamel margins and the dentine enamel junction, or DEJ, the tissue actually becomes healthier.
Right.
So the periphery of your cavity must be established as sound, hard, and utterly caries-free as early as possible in the preparation.
So if you start at the healthy edge and pull your instrument toward the infected center, you're fine. But wait, if the rule is center to periphery, you are moving from dirty to clean. Doesn't that risk dragging infected material onto the healthy margins?
That's a great question. Let's clarify the actual vector of movement. You place the blade of the excavator in the soft necrotic center of the lesion, engage the carious dentine, and cleave it, lifting it away and outward.
Ah, I see. You are removing the bulk of the infected mass from the inside out.
Right. If you were to start at the periphery and push inward, you risk packing infected dentine deeper into the pulpal floor.
Potentially driving bacteria right toward the nerve.
Exactly. And more importantly, establishing a clean periphery first ensures that your final restoration will be sealed against healthy, hard tooth structure.
That makes perfect sense. And the text mentions that cleaving the soft dentine with an excavator provides this distinct, vital, tactile feedback.
Feedback that rotary instruments drills simply cannot match.
Tactile feedback is so critical here. A high-speed drill just obliterates whatever it touches. It doesn't tell you how hard the tissue is.
That is exactly the issue. Dentine undergoes this gradient of decay. You have the heavily infected, soft outer layer that absolutely must be removed.
But beneath that is what the text calls the affected dentine.
Yes, this layer has been demineralized by the acid, so it is softer than healthy dentine, but the collagen matrix is actually still intact, and it does not contain bacteria.
So this affected dentine can actually remineralize and harden over time,
Right.
assuming the cavity is sealed properly above it.
Exactly. But if you use a drill, you blast right through that affected dentine without even feeling it. You unnecessarily remove tissue that could have been saved, bringing you dangerously closer to a pulpal exposure.
But a hand excavator.
A hand excavator allows the clinician's micromotor senses to literally feel the exact transition point, where the soft, mushy infected dentine gives way to the slightly firmer, leathery affected dentine.
Wow. That really is the clinical art of tissue preservation.
It is.
So after the carious dentine is fully excavated, the cavity margins need architectural refinement. This introduces the marginal trimmers on the tray.
Specifically, the U1, U2, and the U3, U4.
These instruments are designed to pare away unsupported enamel from the floor and the vertical walls of a Class II box preparation.
Which is a cavity on the interproximal surface right between the teeth.
This part of the text reminds me of a master carpenter finishing a critical structural joint, like a dovetail joint.
Oh, that's a brilliant biomechanical analogy.
Right, like you can't just hack away at the wood with a dull saw and expect a perfect fit. You have to take a specialized, razor-sharp, angled chisel and shear away any weak, splintered wood fibers.
Because if you don't,
When the final joint is assembled and put under load, it will rest on those weak splinters and the joint will fail.
and enamel behaves very similarly to the grain of wood in this specific context.
Because of the enamel prisms.
Yes. Enamel is composed of millions of microscopic rods, or prisms, running from the underlying dentine out to the surface of the tooth. Enamel is incredibly hard and wear-resistant, but it is also extremely brittle.
It derives its structural integrity entirely from being supported by the resilient, shock-absorbing dentine underneath it.
Exactly. So if your cavity preparation creates a situation where an enamel prism has been cut away from its underlying dentine base, it is now unsupported.
It is literally hanging in midair, At a microscopic level.
Right. And if you leave that microscopic lip of unsupported enamel at the gingival floor of your cavity and then place a filling over it,
Disaster is inevitable.
complete disaster. When the patient chews, the massive hydraulic forces of mastication are transferred through the filling directly onto that unsupported enamel prism.
Because it's brittle and unsupported, it will just immediately fracture and shear off.
It snaps right off. This creates a microscopic gap between your filling and the tooth. Saliva and bacteria rush into that gap, leading to microleakage, devastating secondary caries deep under the restoration.
And clinical failure.
Yes. So the marginal trimmers are designed to prevent this entirely. They have a uniquely curved blade and a highly sharpened leading edge that is cut obliquely.
And the clinician uses this instrument to firmly plane the gingival floor and the vertical walls of the box,
Cleanly shearing away any and all unsupported enamel prisms, leaving only solid, dentine-supported enamel to form the foundation of the restoration.
Now, the protocol specifically notes that you need two distinct double-ended instruments to manage a single tooth, the U1, U2, and the U3, U4.
Yes, you have to switch between them.
But why couldn't an operator just use one instrument and flip it around? Why the necessity for two completely different handles?
It comes down to the geometry of that oblique leading edge, combined with the anatomy of the tooth.
Okay, unpack that.
So, a Class 2 preparation involves creating a box shape. If you are preparing the mesial surface, which is the side of the tooth facing toward the front of the mouth, the angle required to properly plane the gingival floor along the direction of the enamel prisms is completely different than if you are preparing the distal surface.
The distal being the side facing the back of the mouth.
Right. Because the cutting edge is oblique, an instrument designed to cut with a downward pulling stroke on the mesial box will be facing the absolute wrong way to cut the distal box.
So you need two double-ended instruments, one for the mesial, one for the distal.
Exactly. This allows the clinician to sweep the blade buccally or lingually across the floor, ensuring the cutting angle perfectly matches the necessary shear plane for the enamel rods.
The protocol also highlights that some premium trimmers utilize tungsten carbide tips.
Yes, a massive metallurgical upgrade. It maintains the extreme sharpness necessary to cleanly fracture the enamel prisms rather than just dulling out and crushing them.
This really highlights the immense complexity of what seems like a simple physical task.
Yeah.
Knowing exactly how much unsupported enamel to remove, recognizing the microscopic angle of the prisms, understanding the physical forces the final filling will endure.
It requires an absolute fusion of dental anatomy, histology, and material science. That is the essence of the integrated cognitive shift we discussed at the very beginning. The hand instrument is merely a physical extension of that integrated knowledge.
Okay, so let's follow the timeline of a procedure. The disease is diagnosed carefully. The infected tissue is meticulously excavated based on tactile feedback. The architectural margins are refined to remove microscopic points of failure. The tooth is prepped.
Now we move from removal to reconstruction.
The intersection where chemistry meets anatomy. We need to detail the specific instruments used to place, adapt, and condense various restorative materials.
Starting at the deepest part of the cavity with cements and linings.
The tray includes the PF10. This is a double-ended instrument featuring very small ball ends.
And those ball ends are engineered for precise fluid dynamics. When you are placing a lining cement over a deep excavation, particularly in areas closely approximating the vital dental pulp, you are working with microscopic volumes of material.
Because liners are often quite fluid or paste-like, right? They're designed to seal the dentinal tubules and provide a thermal or chemical barrier to protect the nerve.
Exactly. The small spherical shape of the PF10 allows the clinician to pick up a tiny bead of the mixed cement, carry it to the deepest aspect of the cavity, and spread it smoothly and accurately over the pulpal floor.
And the round shape prevents the instrument from catching and dragging the sticky cement back out of the cavity.
Right, there are no sharp edges to pull the material away.
Once the liner is placed, you might need a structural base. We look at the flat plastics, specifically the 179 and the 156.
The 179 is fascinating from an engineering standpoint.
It really is. It's designed for handling putty-like cements, but the blades on each end of the handle are oriented on entirely different planes.
Yes, one blade is completely in line with the handle, like a spade. The other blade is perpendicular to the handle, like a hoe.
Why not just have two inline blades of different sizes?
That orientation is a masterclass in spatial access. A cavity preparation is not a flat canvas. It is a complex, three-dimensional defect located inside a highly restrictive environment. the mouth.
Right.
Imagine you need to apply a structural base cement to the vertical axial wall of a Class 2 box. This is the inner vertical wall facing the adjacent tooth.
Okay, visualizing it.
If you only had an inline blade, you would have to angle the entire handle of the instrument horizontally to press the material flat against that vertical wall. In a patient's mouth, you simply don't have that room. The handle would collide with the cheek or the opposing teeth.
Ah, so the perpendicular blade allows you to approach the tooth vertically from the top.
Exactly. You drop the instrument into the box from above and use a lateral pressing motion against the axial wall, perfectly adapting the cement without space constraints.
And as the protocol outlines, the 156 flat plastic shares this dual plane geometry but features significantly larger, broader working ends.
Which makes it the instrument of choice for rapidly transferring and tamping down bulk temporary dressings, where precision is less critical than volume and speed.
So moving from cements to definitive restorative materials, the protocol dives deeply into amalgam. Amalgam is a classic, durable metallic alloy.
The text details the specific instruments for condensing it, the amalgam pluggers, primarily the O1 and the PF153.
Across these double-ended instruments, there are 4 distinct flat face diameters available. The clinician selects the size based on the specific width of the cavity preparation.
But this is where the physics of the procedure become incredibly critical.
Right. The protocol states explicitly that using a smaller diameter plugger exerts greater pressure on the amalgam, which forces a mercury-rich layer to the surface.
Yes, it does.
I want to push back on this a bit because intuitively, if I want to squeeze liquid out of something like pressing water out of a wet sponge, I would use a large flat spatula to push down on the whole thing at once. Why does a tiny, small diameter plugger push more liquid mercury to the surface?
Your sponge analogy makes sense for a macroscopic object, but amalgam condensation is governed by a strict physics formula. Pressure equals force divided by area.
Force over area.
Right. Imagine standing on a soft wooden floor. If you wear a flat-bottomed snowshoe, your body weight, the force, is distributed over a massive surface area. The pressure at any given point is very low, and the wood is fine.
Okay, sure.
Now, take off the snowshoe and put on a high-heeled stiletto. The force, your body weight, is exactly the same, but the area is now incredibly tiny.
And the pressure at the tip of that stiletto is immense, enough to puncture and dent the hardwood floor.
Exactly the mechanism. Dental amalgam is a particulate alloy silver, tin, copper that is triturated or mixed with liquid elemental mercury. It forms a plastic moldable mass.
And the primary goal of condensation is to aggressively pack those solid alloy particles as tightly together as humanly possible.
Right, forcing them to adapt to the microscopic irregularities of the cavity walls and eliminating any internal air voids. When you apply immense pressure using a small diameter plugger, you physically squeeze the excess liquid mercury out from the spaces between the solid particles.
Because the cavity floor and walls are solid tooth structure, the liquid mercury has nowhere to go but up.
Following the path of least resistance.
It is driven to the top surface of the restoration. But why do we want a pool of mercury-rich amalgam sitting on the top of the filling?
We absolutely do not want it to stay there. That mercury-rich surface layer represents the gamma-2 phase of the set amalgam, which is metallurgically the weakest, most corrosion-prone component of the entire alloy.
So we have to get rid of it.
Yes. The clinical technique demands that the cavity is deliberately overfilled. You pack the amalgam past the enamel margins, driving all that weak liquid mercury up into the overfilled portion.
Then, during the carving phase, you meticulously shave away that entire top layer and discard it.
Exactly. What remains inside the confines of the cavity is a dense, highly packed, structurally superior amalgam matrix with a minimal mercury content. It is a brilliant application of physics to optimize metallurgy.
That perfectly explains the strict handling and environmental protocols that surround this material in the text. The setup describes the amalgam pot, a small, Dappen dish-like receptacle that receives the freshly mixed plastic amalgam from the vibrating capsule.
This allows the clinician to load the amalgam carrier, which is essentially a specialized metal syringe.
Often called an amalgam gun. You press the hollow tip into the pot, it picks up a cylinder of the metal you carry to the mouth, and depress the plunger to express it into the cavity.
And there is an absolute non-negotiable rule here. The pot and the carrier must be entirely emptied and cleaned immediately after use. It is an absolute imperative for 2 distinct reasons: instrument survival and environmental toxicity. If mixed amalgam is left inside the hollow barrel of the carrier, the chemical setting reaction continues unabated.
Within minutes, it will harden into an immovable block of solid metal.
Permanently locking the plunger and completely destroying a highly expensive precision instrument.
And secondarily, from a health and safety perspective, waste amalgam cannot simply be thrown in the trash.
Absolutely not. It must be segregated into specialized sealed containers filled with a chemical suppressant to prevent mercury vapor release and handled according to strict biohazard and environmental regulations.
Let's shift the chemical paradigm entirely and look at composite resin. We are moving from a metallic alloy that is physically wedged into a cavity to a polymer-based resin that chemically bonds to the tooth structure.
And the physical instruments must change to accommodate this chemistry.
Right. The protocol introduces the P1 instrument for placing and shaping composite. It features a cone end for sculpting the sweeping slopes of the cusps and a sharply pointed end for drawing the intricate fissure patterns.
But what is truly vital here is the material the instrument itself is made from.
The text notes that clinicians reach for composite instruments that are specifically gold-plated or have tips coated in Teflon. Why can't you just use the standard, easily sterilizable stainless steel instruments you use for amalgam?
Because of the profound difference in surface energy and chemical interaction.
Meaning how the material sticks.
Exactly. Amalgam is highly cohesive. It wants to stick to itself, but it does not bond chemically to stainless steel. It merely rests against the flat plastic. Composite resin, conversely, is incredibly hydrophobic and sticky in its uncured state.
It is a highly viscous matrix of bis-GMA monomers and silica fillers.
If you attempt to manipulate that sticky resin with a standard stainless steel instrument, the composite will wet the metal surface and aggressively adhere to it.
So you spend 5 minutes carefully adapting the resin against the cavity wall, and the second you try to pull your instrument away,
The resin sticks to the steel and pulls right back out with it. You instantly introduce microscopic voids, you pull the material away from the bonding agent on the dentine, and you completely ruin the anatomical contour you were trying to sculpt.
that sounds immensely frustrating.
Oh, it is. But gold plating and Teflon coatings fundamentally alter the surface energy of the instrument, creating a non-stick, low-friction interface.
The resin maintains its chemical affinity for the primed tooth structure, allowing the clinician to fluidly push, fold, and burnish the composite into place without the instrument grabbing it.
It allows for absolute manipulative control over a difficult, technique-sensitive material.
Okay, so once the restorative material is fully condensed and adapted, whether we're talking about amalgam or composite, the final operative step is shaping.
The tooth must be returned to its functional anatomical form.
We look at the carvers. The protocol details the half-Hollenbach carver, an instrument with opposing leaf-shaped blades that are positioned perpendicularly to each other.
And the specific technique here is fascinating.
Right. The operator rests a portion of the long blade on the surrounding, healthy, uncut enamel slope of the cusp, while the tip of the blade rests in the midline of the soft filling material.
As they drag the instrument along, it carves the correct anatomical slope. The existing tooth is actually acting as a physical guide rail.
That is the defining concept of biomimetic restoration. You are not an artist freehanding a sculpture from memory.
No, you are utilizing the patient's surviving native anatomy to physically dictate the angulation and depth of the instrument, forcing it to recreate exactly what was lost to disease.
The incline of the remaining cusp guides the blade to carve the exact corresponding incline into the filling.
Ensuring that when the patient bites down, the opposing teeth meet in perfect, harmonious occlusion. If you overcarve, the tooth is taken out of the bite, causing the adjacent teeth to bear too much force.
And if you undercarve,
The filling is high, causing immediate trauma to the periodontal ligament. The half-Hollenbach, used correctly against the enamel guide rails, prevents both errors.
the protocol also outlines the Ward's number 2 carver, which shares a similar carving function. But its design intentionally leaves the blade that is in line with the handle completely blunt and unsharpened.
Right. This allows that specific end to double as a safe, flat tool to quickly transfer and pack temporary dressings, maximizing the efficiency of the instrument tray.
Now, up until this point, we've been exclusively exploring the realm of manual finesse. The tactile feedback of the excavator, the precision angulation of the trimmer, the careful packing of materials.
But when a clinician is faced with intact, diseased enamel or an old, failing metallic restoration that must be removed,
Manual finesse is entirely insufficient. Finesse must be paired with overwhelming mechanical power.
we must transition into the engine room of the operative setup.
The handpieces, the Burs, and the physics of high-speed rotary cutting. Let's start with the apex of dental power, The air turbine, universally known as the high-speed handpiece.
The high-speed air turbine is, without hyperbole, one of the most vital engineering marvels in modern medicine.
The mechanics described in the protocol are elegant but devastatingly powerful. It is driven entirely by compressed air, delivered from a compressor unit located elsewhere in the clinic.
This highly pressurized air is channeled up through the umbilical cord, through the body of the handpiece, and directed at precise angles over the microscopic fins of a beautifully machined turbine rotor located directly in the head of the instrument.
And that pneumatic energy is instantly converted into rotational kinetic energy.
The rotational speeds documented here are almost difficult to conceptualize.
I mean, the protocol states it operates at a free-running speed, meaning spinning in the air without touching anything, of 400,000 to 450,000 revolutions per minute.
To put that in perspective, a high-performance sports car engine might redline at 8,000 RPM. This is spinning 50 times faster.
However, when the burr actually makes contact with the tooth structure and begins to cut, it experiences physical drag, and the velocity drops to a cutting speed of roughly 250,000 to 300,000 RPM.
And it is only through that extreme, staggering velocity that the instrument can cleanly cut through hydroxypad enamel.
Because enamel is so hard, it will instantly blunt and destroy lower-speed steel instruments.
Exactly. To manage the speed, air turbines utilize a friction grip chuck mechanism.
The shank of the burr is smooth, right?
Yeah.
Without latches or grooves.
Yes. It is held securely inside the head of the handpiece simply by the immense friction generated by a microscopic metal sleeve clamping down on it, often tightened by a push-button mechanism or a specialized tool.
However, delivering this massive amount of kinetic energy into a hard, calcified tissue generates an inescapable byproduct.
An enormous, catastrophic amount of friction and heat.
Which brings us to the absolutely critical role of the water spray system. A handpiece doesn't just spin, it acts as a highly pressurized water cannon.
It channels water through internal ports to spray a fine, continuous mist directly onto the spinning burr and the impact zone on the tooth.
What happens if those water ports get clogged and the clinician attempts to prepare a tooth dry at 400,000 RPM?
The biological consequences are severe and instantaneous. The water spray performs three absolutely non-negotiable functions. First, it cools the cutting burr itself.
Because if a tungsten carbide burr or a diamond burr operates dry at that speed,
the metallurgical heat will cause the cutting edges to instantly degrade, melt, or shed their diamond grit, rendering the instrument useless.
And
Second, and far more importantly, it cools the biological tissue. The dental pulp, the living nerve inside the tooth, is incredibly sensitive to thermal changes.
The text mentions a specific threshold here.
Yes, research shows that raising the pulpal temperature by just 5.5 degrees Celsius, bringing it from body temperature to roughly 42.5 degrees, will cause irreversible thermal necrosis.
The nerve just dies.
The proteins coagulate, the blood vessels thrombose, and the nerve dies. Cutting dry at 400,000 RPM can spike the temperature well beyond that threshold in less than 3 seconds. The water coolant is the only thing keeping the tooth alive during preparation.
And the third function.
The highly pressurized water spray acts as a continuous hydrodynamic flush. It clears away the slurry of cut enamel, dentine, and old restorative material, ensuring the microscopic blades of the burr do not become clogged and blinded with debris.
Because if they clog, it would drastically reduce cutting efficiency and rapidly increase friction even further.
Exactly. A vicious cycle.
The protocol makes a strong point that because these instruments operate at such extreme tolerances, routine mechanical maintenance is vital.
They must be meticulously cleaned and lubricated, ideally in automated calibrated machines.
If abrasive polishing paste or microscopic tooth dust gets into the turbine bearings, it causes uneven wear, which leads to immediate vibration.
And vibration at 400,000 RPM is profoundly destructive to both the burr and the tooth margins.
Now, alongside the high-speed air turbine, the setup includes the contra-angled, slow-speed handpieces. These operate on a fundamentally different power delivery system.
Right. They are driven either by a pneumatic air motor operating at a modest 6,000 RPM or a highly advanced electric micromotor that can reach up to 40,000 RPM.
These systems utilize latch grip burrs,
which have a physical notch cut into the shank that mechanically locks into a catch inside the head, preventing them from slipping at lower speeds.
This introduces a highly nuanced clinical trade-off that the operator must constantly evaluate.
The core difference between an air turbine and an electric motor is torque. the actual rotational twisting force behind the spin.
An air turbine spins incredibly fast, but it has very low torque, right?
Yes. If you press too hard against the tooth, the air resistance overcomes the turbine fins, and the burr will simply stall and stop spinning. It forces a light touch.
An electric micromotor, however, provides massive, relentless torque.
And the protocol points out a significant modern trend: the use of a speed-increasing contra-angle handpiece driven by an electric micromotor.
By utilizing internal gearing, usually a 1:5 ratio, the 40,000 RPM output of the electric motor is geared up to drive the burr at 200,000 RPM.
This rivals the cutting speed of the air turbine, but because it is mechanically driven by a physical electric motor rather than air over fins, it maintains massive, unstoppable torque.
When it hits dense enamel or hard metal, it does not slow down. It powers straight through.
But the protocol immediately outlines the grave disadvantage of combining high speed with relentless high torque.
It is a double-edged sword.
Exactly. The greater the mechanical torque and the physical gearing inside the handpiece head, the greater the vibration transmitted through the burr into the tooth and directly into the patient's skull, which can be highly unpleasant.
Far more concerningly, that relentless torque means the burr continues to grind against the tooth structure with immense force, even under pressure.
This generates a significantly higher rate of frictional heat. The risk of elevating pulpal temperatures past that critical 42.5-degree threshold is much higher with a speed-increasing electric handpiece than with an air turbine.
So the clinician must constantly modulate their pressure, utilizing an intermittent brushing stroke.
To allow the water coolant time to dissipate the heat, balancing the sheer efficiency of cutting against the fragile biological tolerance of the pulp.
To actually execute that cutting, we need the active interface, the burrs themselves.
The basic anatomy of a burr is straightforward: the head, the neck, and the shank.
But the metallurgy and the physical mechanism of how they interact with the tooth vary wildly depending on what they are made of. The protocol draws a sharp distinction between steel or tungsten carbide burrs and diamond-coated burrs.
This is a fundamental lesson in operative physics. Steel and tungsten carbide burrs are constructed with actual physical cutting blades, referred to as flutes.
They operate by mechanically slicing and shearing away the tooth structure.
The protocol explains that the precise geometry of these blades is engineered for highly specific outcomes. If the manufacturer cuts the blade at an obtuse angle, it creates a thicker, stronger edge.
This improves the longevity of the burr and prevents the brittle carbide from chipping when hitting hard amalgam, but it cuts slightly slower.
If the blade is cut at a highly acute angle, it produces a razor-sharp edge that shears through dentine beautifully, but degrades faster.
Some carbide burrs feature crosscuts, horizontal notches cut across the vertical blades to break up the debris into smaller chips and improve cutting efficiency.
However, the text notes that with the advent of ultra-high-speed handpieces, crosscuts are largely unnecessary and can actually leave an unacceptably rough surface on the cavity walls.
And how do diamond burrs fundamentally alter that physical interaction?
Diamond-coated burrs do not possess blades or flutes. Their working heads are electroplated and bonded with thousands of microscopic shards of industrial diamond grit.
Therefore, they do not slice or shear the tissue, they brutally abrade it.
They scratch and grind the enamel into dust. Because the physics of abrasion involves millions of microscopic impact points dragging across the surface, rather than a single sharp blade cleanly slicing through it, diamond burrs generate astronomically more friction and heat than carbide burrs.
Which mandates absolute flawless adherence to copious water coolant protocols or pulpal death is guaranteed.
Exactly.
When you really pause and visualize this scenario, a diamond-coated instrument spinning at 400,000 revolutions per minute, mere millimeters from the tongue, the cheek, and the delicate pulp chamber.
The sheer velocity and potential for violence is terrifying if it's not perfectly, absolutely controlled.
This extreme mechanical power necessitates flawless physical and ergonomic control. Which brings us to the biomechanics of the operator. How does a clinician safely harness this chaotic power without injuring the patient?
The protocol is absolute on this point. Severe hard and soft tissue trauma is the immediate, unavoidable consequence of a lack of control.
A burr slipping off a tooth at that speed will wrap up the soft tissues of the cheek and cause deep lacerations instantly.
To safely harness this power, the operator must master two strict physical disciplines: the modified pen grip and the rigid finger rest.
The handpiece is never held in a fist. It is held using a modified pen grip. Visualizing the handpiece exactly like a heavy fountain pen makes a lot of sense.
The text notes that holding it this way, Resting on the middle finger and guided by the thumb and index finger allows for minute, highly precise lateral movements.
You aren't moving your entire arm or wrist to guide the drill. The force is exerted by microscopic flexions of the thumb balanced against the forefinger. It is entirely about micromotor proprioception.
But that delicate micromotor control is entirely useless and highly dangerous without absolute structural stability. We can look back at the analogy you introduced earlier of the high horsepower sports car.
Right. You can build an engine with unbelievable power, but if you drop that engine onto a chassis with a broken suspension, flat tires, and loose steering, the car is undrivable. It's an uncontrollable hazard.
The rigid suspension is what anchors all that chaotic power to the road and makes it functional.
In the biomechanics of operative dentistry, the finger rest is the suspension.
It acts as a Class 3 lever system. The protocol states that the fine, minute control of the handpiece requires a completely stable finger rest, a fulcrum established firmly on immovable hard tissue.
This typically involves resting the pad of your third or fourth finger firmly onto the adjacent teeth or solid teeth on the contralateral side of the dental arch.
This rock-solid anchor point provides the physical fulcrum from which the thumb and forefinger can safely execute those minute, sweeping movements with the burr.
And the expert warning issued in the protocol is incredibly stern here. Under no circumstances should a finger rest ever be placed on mobile soft tissues.
Never.
I want to emphasize why this is so critical. If you rest your stabilizing ring finger on the patient's cheek, their chin, or their lower lip to support your hand,
You have anchored a 400,000 RPM cutting instrument to a moving target. If the patient swallows, if they twitch, if they attempt to speak, or if the muscles of mastication simply spasm, the soft tissue moves.
if the tissue moves, your fulcrum moves.
And if your fulcrum moves while you are actively applying a diamond burr to the pulpal floor, the handpiece will violently slip.
This results in the catastrophic accidental exposure of the dental pulp, necessitating a root canal or a massive laceration of the tongue or buccal mucosa.
The anchor point must be anatomically immovable.
So let us synthesize everything we have covered into the final clinical challenge. The disease was diagnosed without cavitation trauma.
The infected dentine was excavated via tactile feedback.
The unsupported enamel prisms were sheared away by the tremors.
The cavity is safely and precisely prepared using heavily cooled, rigidly controlled, high-speed instruments.
Now the clinician faces a complex architectural deficit. When a carious lesion occurs on the interproximal surface, the area directly between two adjacent teeth, the preparation inevitably requires the removal of an entire supporting vertical wall of the tooth.
You are left with a Class 2 cavity that is completely open on one side.
If you attempt to pack amalgam or composite into that void, the high-pressure condensation we discussed earlier will simply push the material straight out the open side, flooding it into the interproximal gap and burying it deep under the gums.
We have to rebuild the missing wall before we can fill the cavity. This introduces the absolute necessity of matrix systems.
A matrix system is fundamentally a temporary formwork, exactly like pouring concrete for a foundation wall.
The protocol outlines 3 primary non-negotiable functions of a matrix band. First, it acts as a rigid, temporary physical wall to retain the filling material within the confines of the cavity during the extreme pressure of placement and condensation.
Second, it provides a perfectly smooth barrier to ensure the filling material adapts closely and flawlessly to the deep cervical margins of the tooth at the gingival floor.
If the material overhangs that margin, it creates a plaque trap that will destroy the periodontal bone.
And third, and most crucially, it physically reestablishes the anatomical contour of the tooth and the exceptionally tight contact point with the adjacent tooth.
A tight contact point is vital. If it is left open or loose, fibrous foods like meat will pack between the teeth every time the patient chews, driving down into the gums, causing severe localized periodontitis, bone loss, and intense pain.
To achieve these 3 goals across wildly varying anatomical situations, the protocol categorizes matrix systems into 3 distinct architectural types. Type 1 is the encircling matrix.
In a Type 1 system, a ribbon of thin stainless steel matrix band wraps entirely around the full circumference of the tooth. It is locked into a mechanical retainer device that is positioned on either the buccal or lingual side of the tooth.
The protocol cites the classic Toffelmeier and the Seekland systems as the gold standards for this.
Because the band encircles the entire 360 degrees of the tooth, turning a screw on the retainer physically tightens the loop, shrinking its circumference.
This provides an incredibly firm, tight adaptation of the band to the remaining cervical tooth structure, creating a highly resistant wall against which amalgam can be aggressively condensed.
But a full encircling band has limitations, particularly when the teeth are crowded. This leads to type 2, which is the three-quarter encircling matrix.
The protocol mentions the older ivory retainer, which has sharp jaws that aggressively impinge directly into the interdental embrasure space, but it places heavy emphasis on the newer, advanced sectional matrix systems, like the Pelodent.
The sectional matrix system has revolutionized modern composite dentistry. Instead of a long band wrapping all the way around the tooth, you utilize a small, highly contoured, kidney bean-shaped piece of thin metal, the sectional matrix.
This small piece is carefully slid between the teeth, covering only the missing wall.
It is then held rigidly against the prepared tooth by a very strong horseshoe-shaped metal spring ring that is clamped over the adjacent teeth.
The protocol points out that this Type 2 system is absolutely essential when the anatomical contact points between the teeth are incredibly tight.
In those situations, trying to force a full circular band down through too tight contacts often permanently distorts or crinkles the metal, ruining the contour. The sectional matrix bypasses this.
Furthermore, the immense clamping force of the metal spring ring physically separates the two teeth by a fraction of a millimeter.
When the composite is cured and the rings is removed, the periodontal ligament relaxes and the teeth spring back together, forming an incredibly tight, perfectly natural anatomical contact with the newly placed restoration.
Finally, we have Type 3, the matrix with no external retainer at all. The protocol cites the Automatrix system as the prime example.
The system utilizes a small, built-in spring or winding coil mechanism directly on the band itself to tighten it around the tooth, entirely eliminating the need for a bulky, heavy metal retainer sticking out of the patient's mouth.
And exploring why a clinician would choose a Type 3 system brings us perfectly full circle to the underlying philosophy of this entire text.
The protocol notes that the Automatrix is highly advantageous, often the only viable option for severely broken down teeth.
If a tooth has lost 3 of its 4 walls to massive decay, the sharp retaining jaws of an ivory retainer or the heavy tightening clamp of a Toffelmeyer have absolutely no solid tooth structure to grip onto.
They will simply slip off under tension. The Automatrix wraps and tightens upon itself, utilizing the remaining root structure as an anchor.
The clinician is engaged in dynamic, real-time, applied problem solving. They must look at the physical ruin of the tooth, assess the specific biomechanical reality, the tightness of the adjacent contacts, the sheer volume of missing walls, the subgingival depth of the cervical margin, the choice of composite versus amalgam.
And synthesize all that data to select the precise architectural tool required for success. It is the perfect embodiment of the clinical art in motion.
This has been an incredibly profound journey through the source material. We started by defining the absolute necessity of breaking down academic silos and reorganizing preclinical facts into integrated, functional clinical knowledge.
We explored the high-stakes optical physics of front-reflecting mirrors and confronted the vital realization that an aggressive physical probe can shatter a remineralizing front and accelerate the very disease it seeks to diagnose.
We walked through the precise, tactile mechanics of cleaving infected dentine and shearing unsupported enamel prisms, drawing the direct parallel to a master carpenter, ensuring structural integrity.
We explored the material science dictating the use of gold-plated non-stick instruments for hydrophobic composite resins and the high-pressure physics force over area required to condense amalgam and drive the weak gamma-2 phase mercury to the surface.
We stepped into the engine room, breaking down the staggering velocity and fluid dynamics of the 400,000 RPM air turbine, the dangerous thermal trade-offs of electric micromotor torque, the metallurgical differences between shearing carbide flutes and abrading diamond grit,
and the absolute unyielding necessity of the immovable finger rest to prevent catastrophic trauma.
Finally, we looked at the architectural challenge of matrix systems, utilizing spring rings and hoop stress to rebuild the missing walls of a tooth based on its unique biomechanical breakdown.
It serves as a comprehensive, deeply analytical overview of exactly how raw biological science and mechanical physics are translated into the precise physical actions that save teeth.
But as we reflect on the entirety of this protocol, I want to return to that critical paradigm-shifting warning regarding the diagnostic probe.
The source material definitively states that a simple, hardened metal probe used with force can cause iatrogenic damage. It can irreversibly break down fragile remineralizing enamel and actively accelerate the cork-curis process.
This is a recognized profound flaw in our current physical diagnostic interface. It acknowledges that our primary physical intervention carries an inherent, dangerous biological risk.
Which leaves us with a highly provocative thought to carry forward into the future.
If the mere act of physically touching a fragile, microscopic lesion can destroy its ability to heal naturally, how long will it be before the entire concept of minimally invasive dentistry evolves to eliminate physical probing altogether?
Are we currently standing on the precipice of an era where purely optical, non-contact diagnostic technologies, perhaps advanced near-infrared transillumination, optical coherence tomography, or highly sensitive laser fluorescence, entirely replace the sharp metal explorer in the diagnostic tray?
It is a fascinating proposition for you to carry into your clinical future as the integrated art of operative dentistry continues to rapidly evolve.
It truly is.
For more insights into the future of reconstructive medicine, please subscribe and share this update.